You've probably noticed it by now.
Oh, it's everywhere.
Right. I mean, it's practically impossible to scroll through your news feed, turn on the TV, or, even go to a dinner party these days without hearing about the modern revolution in weight loss and diabetes medications.
It completely dominates the cultural conversation right now.
It really does. We are living in a zeitgeist that's just entirely dominated by 3 letters and a number, GLP-1.
Yeah, that's the one.
But here's the thing about all that noise, and this is what we're getting into today. Almost all of that mainstream hype, all those breathless headlines, the celebrity testimonials, they're entirely focused on the injectables.
Right, the pens.
The pens, the needles, the weekly shots you have to keep in your fridge. But what if I told you that quietly, operating just outside the glaring spotlight of all that hype, there's a medical marvel that has completely revolutionized this treatment landscape in a totally different way?
And honestly, from a purely scientific standpoint, it's a much more impressive achievement.
Exactly. We're talking about a delicate, fragile peptide that somehow, against all biological odds, manages to survive the incredibly harsh, acidic environment of your stomach.
Which is a wild concept when you break it down, because if you think about how our bodies are actually designed, the human stomach is essentially a highly efficient incinerator.
An incinerator.
Yeah, specifically for proteins and peptides. It is built to rip them apart the second they arrive. So getting a peptide drug to pass through that literal vat of hydrochloric acid intact and then actually get absorbed into the bloodstream, I mean, that was considered an impossible dream in drug development for decades.
But today, we're not just theorizing about it. We're looking at the reality of that achievement. And that's the specific focus of today's deep dive.
Huh.
We are exploring Rybelsus.
Which contains the active ingredient semaglutide.
Right, semaglutide. But again, we aren't talking about the injectable pens everyone knows about.
Right.
We are stepping into the fascinating, highly specific, and honestly, incredibly rigid world of the oral tablet version.
It's a whole different ballgame.
Totally. And to do this properly, to really give you the full picture, we've brought together a really comprehensive stack of sources from the iMedix medical content engine.
Specifically, we're looking at a deeply detailed, recently updated guide authored by Dr. Catherine Lanier.
Yeah, and that was also peer-reviewed by Dr. Carlos Majorana.
And it's worth noting why we're utilizing iMedix for this specific deep dive. Because iMedix is an independent medical information platform, but they don't just provide a sterile, massive drug database.
Right. It's not just lists of chemicals.
Exactly. They offer extensive educational resources, and crucially, they host incredibly active patient forums. It's a platform that really bridges the gap between the strict clinical data and the actual lived day-to-day human experience of managing these complex health conditions.
I love that aspect of it, because the human element is what makes all this science actually matter. So our mission today, for you, the listener, is to completely decode this drug. We're going to unpack the ridiculously strict rules for taking it.
And they are strict.
Oh, beyond strict. We'll get into the fascinating pharmacology behind how it actually works. And some hidden safety considerations that you absolutely need to know. We're separating the medical reality from the mainstream hype so that you are fully informed.
And we're going to make sure we go far beyond just reading off a list of side effects like some late-night pharmaceutical commercial.
Yes.
What we want to do is connect the dots for you. We'll look at exactly how this drug acts systemically in the body and connect that directly to why patients are required to follow such unusually rigid daily routines. Because there's a profound physiological why behind every single instruction on that Rybelsus label.
And understanding that why completely changes how you view the entire treatment. I have to tell you, digging into this research, I had a massive aha moment about how this little pill actually pulls off its magic trick in the body. I can't wait to get into it.
Let's do it.
So let's jump into the origin story. Because to understand why an oral version of semaglutide is such a monumental big deal, we have to look at where it came from.
The history here is actually pretty recent.
Right, this all starts with Novo Nordisk, the Danish pharmaceutical giant.
Wow.
According to the iMedix historical data, they developed semaglutide, and the injectable form, which everyone knows as Ozempic, was first approved by the FDA back in 2017.
Right, and 2017 was undoubtedly a watershed moment for managing type 2 diabetes. The efficacy of injectable semaglutide was undeniable.
It worked incredibly well.
It did, but the scientific community knew that an injectable drug, no matter how miraculously effective it is, always presents a massive barrier for patients.
Because people just hate needles.
Exactly. People simply don't like injecting themselves. Compliance drops significantly when you ask someone to do that every week. So the massive holy grail scientific challenge was to take this highly effective molecule, semaglutide, and turn it into a pill you can just swallow with your morning coffee.
Which sounds simple until you remember the incinerator we talked about.
Stomach acid.
Yeah, because semaglutide is a peptide, right? And peptides are essentially just short chains of amino acids. They're proteins.
Basically, yes.
So when you swallow a protein, whether it's, I don't know, a piece of steak or a highly advanced peptide drug, your stomach acid and digestive enzymes like pepsin immediately attack it.
They slice it up into individual amino acids before it can ever reach your bloodstream to do its job.
So the drug would just be food to your stomach.
Precisely. What's fascinating here is the sheer gravity of bypassing the stomach's natural defenses. The researchers had to figure out a way to escort this incredibly fragile semaglutide molecule through a pool of acid that can literally dissolve razor blades.
That is terrifying and amazing.
They had to protect it from being enzymatically digested and then somehow coax the stomach lining into absorbing a molecule that is technically too large to easily pass through those cellular barriers.
And here is the aha moment for me in the research. They didn't just tweak the semaglutide molecule itself to make it tougher. They gave it a bodyguard.
A chemical bodyguard, yeah.
They achieved this by pairing the semaglutide with a very specific absorption enhancer. It's called SNAC.
SNAC.
Right. It stands for sodium N8-2-hydroxybenzoyl aminocaprylate. I practiced that.
You nailed it. But yeah, SNAC is easier.
Much easier. But it's a brilliant piece of chemistry. When this pill hits the stomach, the SNAC creates a temporary, localized increase in pH. It essentially acts like a microscopic buffer.
It neutralizes the stomach acid just in the immediate millimeter of space around the dissolving pill.
That's the key part. It's not neutralizing your whole stomach like an antacid would. It's just creating a tiny safe zone.
Exactly. And simultaneously, that SNAC compound interacts with the lipid membranes of the stomach cells, briefly making them more fluid and permeable.
So it opens the door.
It opens a door just long enough to allow the semaglutide to slip through the gastric lining and into systemic circulation. It is a highly choreographed molecular dance.
It's incredible. And this monumental breakthrough is what ultimately led to the FDA approving Rybelsus in 2019, cementing its place as the very first oral GLP-1 receptor agonist in medical history.
It changed the game entirely.
They essentially built a tiny chemical Trojan horse to get this medicine where it needs to go. But, and this is the next big question, once it's inside the gates, once that semaglutide actually survives the journey and it's circulating in your system, what is it actually doing?
That's where we get to the core mechanism of the drug.
Right. The iMedix guide outlines what I like to call the trifecta of glycemic control.
The trifecta is the perfect way to frame it, because it really does work on 3 distinct, synchronized physiological levels.
So break that down for us. What's the first one?
The first action, and perhaps the most crucial for diabetes management, is that it stimulates the release of insulin from the beta cells in the pancreas.
Okay, more insulin to process the sugar? But the brilliance of it and why it's so vastly superior to older diabetes drugs like sulfonylureas is that it does this in a purely glucose-dependent manner.
Yes, that is a critical distinction.
It's not just indiscriminately squeezing the pancreas to pump out insulin all day long, regardless of what you've eaten.
Precisely. The GLP-1 receptors in the pancreas are only activated by the semaglutide when blood glucose levels are elevated. So like right after you eat a meal.
When you actually need the insulin.
Exactly. When your blood sugar is normal or low, the drug essentially sits back. It doesn't force more insulin out. This drastically reduces the risk of severe hypoglycemia or dangerously low blood sugar compared to those older medications.
Okay, so it's smart. It steps on the gas for insulin only when the environment calls for it. What about the second mechanism in this trifecta?
The second action is that it simultaneously suppresses the release of glucagon from the alpha cells of the pancreas.
Glucagon being?
Glucagon is the hormone that acts as the counter-regulatory signal to insulin. It tells your liver to release its stored sugar into the bloodstream.
I see.
So by suppressing glucagon in a glucose-dependent way, semaglutide prevents the body from needlessly dumping more sugar into the blood when levels are already too high.
So it's pumping the brakes on the liver while stepping on the gas for the pancreas. It's a beautiful push-pull system. More insulin when you need it, less glucagon when you don't.
It restores a natural balance that is broken in type 2 diabetes.
And the third action?
The third action happens in the gut and the brain. It significantly slows down gastric emptying.
Meaning it physically slows down how fast your stomach empties digesting food into your small intestines.
Right.
Which makes perfect sense for blood sugar control when you think about it. If the food leaves the stomach slower, the carbohydrates are broken down slower.
Exactly.
Which means the glucose from your food enters your bloodstream in a slow, steady trickle rather than causing a massive post-meal spike.
That's exactly it. It smooths out the whole curve. And if we connect these three actions back to the primary medical use, it's very clear why this is such a powerful clinical tool. All three of these mechanisms work in concert to lower HbA1c.
The A1C test.
Right, which is the gold standard measure of a person's average blood sugar over a 2 to 3 month period. For adults with type 2 diabetes, lowering that HbA1c is the ultimate goal to prevent long-term devastating complications. Things like neuropathy, kidney failure, blindness.
And of course, the iMedix sources heavily emphasize that Rybelsus is meant to be used alongside a solid foundation of diet and exercise.
Oh, absolutely.
It's a powerful adjunct, right?
Yeah.
It's not a standalone magical cure that lets you eat donuts all day and just take a pill.
No medication can outwork a terrible diet. It's designed to assist, not replace, lifestyle changes.
Okay, let's unpack this. Because knowing how it works is fascinating, but it's really only half the battle.
The easy half, honestly.
Yeah, because the other half is actually taking the medication, and this is where the reality of that chemical Trojan horse hits your daily routine. Reading the general instructions on the iMedix platform, the rules for taking Rybelsus are incredibly strict. It's not just a suggestion, it's a rigid daily ritual.
Unforgiving is probably the most accurate word for it.
Unforgiving, I like that.
You have to remember how fragile that SNAC absorption enhancer is. That microscopic safe zone of neutralized acid we talked about. That process is so delicate that if you deviate even slightly from the administration instructions, you will destroy the medication before it ever gets absorbed.
I really want to detail the exact timing and conditions for you here, because it's wild when you think about integrating this into a normal human morning. First, you must take this pill absolutely first thing in the morning.
On a strictly empty stomach.
Strictly empty.
Huh.
You can't take it after your morning protein shake. You can't take it midday because you forgot. You wake up, your feet hit the floor, and this is step one.
And step 2 is the fluid constraint, which is where a huge percentage of patients make a critical error. The tablet must be swallowed whole with no more than 120 milliliters of plain water.
And for those of us using imperial measurements, that is exactly 4 ounces.
4 ounces.
I want you to visualize that. 4 ounces is just a tiny sip. It's barely a quarter of a standard disposable water bottle.
It's barely enough to get a pill down for some people.
And the iMedix guide is militant about this. It has to be plain water. No coffee, no orange juice, no tea, no lemon water, nothing else.
The reason for this strict fluid constraint ties directly back to the pharmacology of that SNAC molecule.
The bodyguard.
Right. If you drink a large 8-ounce glass of water to wash down the pill, you completely dilute that local pH neutralizing effect the SNAC is trying to create in your stomach.
Oh, so you just drown the bodyguard.
You literally wash it away. Too much water washes the buffer away, leaving the semaglutide completely exposed to the stomach acid where it's instantly obliterated. Taking it with too much water renders the medication clinically useless.
Wow. So you wake up, take the pill with a tiny measured sip of water. But then comes what I think is the hardest part, the waiting period.
The infamous 30 minutes.
The patient must wait at least 30 minutes before eating anything, drinking anything else, or taking any other oral medications.
And that 30-minute window isn't arbitrary. It is the absolute minimum pharmacokinetic time required for the tablet to dissolve, for the SNAC to do its buffering work, and for the stomach lining to actually absorb the heavy semaglutide molecule.
So if I were to just eat a piece of toast at minute 15...
You'd ruin it. If you introduce food, other liquids, or other pills into the stomach during that critical half-hour window, you disrupt the pH, you trigger digestive enzymes, and the absorption drops to near zero.
I really want you to imagine applying this to your actual everyday life. Imagine trying to navigate a busy, chaotic morning routine. You're trying to get the kids dressed for school, you have a massive presentation at work, you're exhausted, you've got emails piling up, but you can't touch your coffee maker.
Not a drop.
You can't have a quick piece of toast, you can't even take your daily multivitamin or your blood pressure medication yet. You have to wait, literally watching the clock for a full 30 minutes, staring at the coffee pot, just to accommodate this one single tablet. It is a massive behavioral intervention just to get the drug into your blood.
It really is. It demands a level of patient compliance that we rarely see outside of very specific oncology protocols. It forces a complete routine change.
And the physical rules for the tablet itself are just as strict. You can never split, crush, or chew the tablet.
Right, because splitting or crushing it would completely destroy that protective SNSC formulation before it even reaches the acid. The delivery system is entirely dependent on the tablet remaining perfectly intact until it hits the stomach floor.
So you can't just cut it in half to save money or ease into the dose.
Absolutely not. Compliance isn't just about taking it, it's about taking it perfectly.
So naturally the question is, what happens if life gets in the way and you mess up? What if you oversleep and just forget?
It happens to everyone.
The consistency and storage rules detailed by Dr. Linauer on iMedix are very clear about the missed dose protocol. If you miss a dose, you skip it entirely. You just take the next one the following day at your regular time. You never, ever gobble up to make up for a missed dose.
And that's a crucial safety point. Because of the drug's long half-life, doubling up would lead to a dangerous compounding spike in systemic medication levels. That drastically increases the risk of severe side effects, which we'll get into shortly.
And maintaining that exact consistency extends to how the drug is physically stored in your house. The storage requirements blew my mind.
People don't realize how sensitive it is.
The iMedix guide explicitly states it must be kept at room temperature, between 20 to 25 degrees Celsius. But here's the critical part that trips people up. It absolutely must be kept in its original blister packaging to protect it from moisture.
You can't take them out.
Right. You can't pop a week's worth of these out and organize them in one of those handy Monday through Sunday plastic pill organizers.
It's because the SNIC formulation is highly hygroscopic.
Meaning it absorbs water.
Exactly. It actively pulls moisture out of the air. Exposing the tablets to ambient moisture in your bathroom air or in a pill box will begin to degrade the absorption enhancer before you ever swallow it.
So this blister pack isn't just to be annoying.
No, the blister pack is not just for convenience or child safety. It is an active, necessary protective barrier that is scientifically essential to the drug's efficacy.
It's honestly wild how precise this entire sequence has to be. You're basically running a tiny chemistry lab in your kitchen every single morning.
You really are.
But let's shift gears a bit, because while the primary medical use and the delivery system are fascinating, there's a massive elephant in the room that we absolutely have to address. I think this is where the cultural conversation really gets tangled up.
The weight loss aspect.
Yes. The iMedix guide notes that many patients are surprised to find weight reduction as what the clinical literature gently calls a beneficial secondary clinical effect.
It's the most common point of confusion, and frankly, it's the main reason the GLP-1 class is dominating the zeitgeist. But it's vital that we provide the strict regulatory context here.
Right.
Rybelsus, this specific oral tablet, is FDA approved only for glycemic control in adults with type 2 diabetes. That is its sole official on-label indication.
But the active ingredient is semaglutide. Right. And semaglutide is globally famous for weight loss. I mean, it's the drug all the influencers are talking about. So let's draw some clear distinctions between the available forms of semaglutide based on the source text, because it's kind of like looking at siblings in a family.
That's a great analogy.
They all share the exact same chemical DNA, but they have very different jobs and different strengths.
Let's look at the three siblings. First, you have Rybelsus, the daily oral pill we're discussing today, approved strictly for type 2 diabetes.
Okay.
Then you have its older sibling, Ozempic. Ozempic contains the exact same active ingredient, semaglutide, but it's a once-weekly injectable. Because it's injected directly into the subcutaneous tissue, entirely avoiding the gauntlet of the stomach, it achieves much higher and more stable blood concentrations.
It's more powerful.
Yes. And like Rybelsus, Ozempic is approved for type 2 diabetes, but because of those higher blood levels, it carries an additional, highly sought-after FDA approval for cardiovascular risk reduction.
And then there's the third sibling, wegovy, which is the one making all the headlines everywhere.
Exactly. Wegovy is also a once-weekly injectable form of semaglutide, but it's administered at significantly higher doses than Ozempic, up to 2.4 milligrams. And Wegovy is the sibling specifically approved by the FDA for chronic weight management in people with obesity or overweight individuals with related comorbidities.
This is such an important distinction for you to understand if you're navigating this space. Because of the intense public demand, people are seeking out any form of semaglutide they can find. But using Rybelsus, the oral pill purely for weight loss in non-diabetics, is strictly considered off-label use.
And it comes with risks.
The iMedix text is very clear that if this is happening, it requires incredibly careful management by a physician. You are dealing with astronomical out-of-pocket costs and significant side effects for a medication that was not specifically calibrated or approved for that standalone purpose in this oral form.
And the oral bioavailability is so low, it's about 1%, that you have to take 14 milligrams orally just to get a fraction of the effect of a 1 milligram injection.
Just 1% actually makes it into the blood.
Yeah, even with the SNSC Bodyguard, it's highly inefficient compared to an injection. It really highlights the critical importance of matching the specific formulation, the delivery method, and the dosage to the actual medical diagnosis.
But beyond the blood sugar control and the intense focus on weight loss, there's another monumental aspect to semaglutide that often gets buried in the mainstream chatter, and it's arguably the most important for long-term health.
You're talking about the cardiovascular benefits.
Exactly. The iMedix clinical data highlights that semaglutide, the active ingredient itself, has been shown in massive clinical trials to actually reduce the risk of major adverse cardiovascular events. They call this MAC in the literature.
Right, MAC, major adverse cardiovascular events.
We're talking about actively preventing non-fatal heart attacks, non-fatal strokes, and cardiovascular death in adults with type 2 diabetes who already have established heart disease.
If we connect this to the bigger picture of modern medicine, this represents a massive tectonic paradigm shift in how endocrinologists treat metabolic conditions.
How so?
Well, historically, diabetes medications were judged almost entirely on their ability to lower blood sugar, lower the A1C, and that was the finish line.
Just fix the number on the paper.
Exactly. But diabetes is inherently a vascular disease. It destroys blood vessels over time. Now, with the GLP-1 class, we are seeing the evolution of diabetes medications from simply managing a number on a lab report to actively protecting the endothelial lining of the heart and brain.
That is incredible.
Reducing those major adverse cardiovascular events changes the entire trajectory of a patient's life. It's not just about managing glucose anymore, it's about fundamentally extending life and improving the quality of those years.
It really is a totally new era. It's almost like treating the root of the vascular damage rather than just the glycemic symptom.
It's proactive rather than just reactive.
But getting those incredible long-term benefits means you actually have to stay on the medication.
Yes.
And that brings us to the hardest part for many patients, the sheer physical toll of the side effects. Looking at the dosing schedule on iMedix, it's not a one-size-fits-all start on day one situation.
Not at all.
It's what I envision as a very long, very deliberate dosing staircase. And honestly, looking at how slow it is, I'm really curious about why it requires such a drawn-out buildup.
The slow buildup is an absolute physiological necessity because of how the human gut reacts to sudden exposure to GLP-1 receptor agonists. It completely floors you if you aren't careful.
So let's break down those phases because they are rigidly defined. The initiation phase starts at a very low dose of 3 milligrams, taken once daily for a full 30 days.
30 whole days.
30 whole days on just 3 milligrams. And the iMedix guide makes a really interesting point here that a lot of patients don't realize. That 3 milligram dose isn't even meant to control your blood sugar, is it?
That is correct, and it's a frequent point of frustration for patients who expect immediate results. They take it for a week and say, my numbers haven't moved.
Because it's not supposed to yet.
Right. The 3 milligram initiation dose is considered subtherapeutic for glycemic control. Its sole purpose is to help your central nervous system and your gut receptors acclimate to the presence of the drug, and to intentionally minimize the severe gastrointestinal side effects that would absolutely destroy a patient if they started at a higher dose.
So it's purely about building biological tolerance.
Exactly. You are just introducing the compound to the body.
Okay, so after you survive the first 30 days on the 3 milligram step and your gut has hopefully adjusted, you move up to maintenance step 1. That's 7 milligrams once daily, and you had to be on that for at least another 30 days.
Right.
And then finally, if you need additional glycemic benefit, and crucially, if your body is tolerating the 7 milligrams, you can move up to maintenance step 2, which is the maximum approved oral dose of 14 milligrams once daily.
And this is exactly why patience is critical. According to the FAQs and clinical data in the iMedix guide, it takes a full 8 to 12 weeks of consistent, perfect daily use at those maintenance doses, the 7 milligram or 14 milligram levels, to actually see the full, stable HbA1c lowering effect.
8 to 12 weeks.
It is a major long-term commitment. You are slowly walking up that staircase, letting your system neurologically and gastrointestinally adjust at every single landing.
And what exactly is this system adjusting to? Because the side effects are notorious. Let's list the very common side effects straight from the source literature. We are talking about severe nausea, diarrhea, vomiting, abdominal pain, and heavily decreased appetite.
They are very intense.
The literature points out that these issues really peak when you're first starting a medication or right when you step up to a higher dose on that staircase.
The gastrointestinal distress is directly tied to the drug's mechanism of slowing down gastric emptying.
The third part of our trifecta.
Exactly. When your stomach takes much, much longer to process food and move it into the bowel, it naturally leads to profound feelings of intense fullness, bloating, and nausea. The vagus nerve is essentially constantly signaling to your brain that you are stuffed to the brim, even if you've barely eaten.
So your brain thinks you just ate Thanksgiving dinner constantly.
Yes.
The iMedix guide actually provides some very practical, highly necessary advice for you if you're navigating this phase. They suggest eating much smaller, bland, low-fat meals. Think crackers, toast, rice, the kind of stuff you eat when recovering from the flu.
It's basically a flu diet.
You have to actively avoid spicy, greasy, or overly sweet foods. If you eat a greasy cheeseburger while your gastric emptying is delayed by Rybelsus, that fat is just going to sit in your stomach like a rock for hours and drastically exacerbate the nausea and vomiting.
It's awful.
And they emphasize that you need to sip water frequently to stay hydrated.
And I want to pause on that point about hydration because it's not just a comfort measure to make you feel better. It is a critical, life-saving medical directive.
How so?
Let's talk about the cascading physiological effect of these side effects. If a patient is experiencing severe nausea, they aren't drinking enough water. If they are simultaneously experiencing vomiting and diarrhea, they are rapidly losing whatever fluids they do have. This leads directly to systemic dehydration.
And dehydration isn't just about feeling thirsty. When you're managing diabetes, dehydration is where things get really serious, especially for the kidneys, right? Because we're talking about blood volume dropping.
Exactly. When you become severely dehydrated, your overall blood volume decreases. This means the perfusion, the physical flow of blood to your kidneys, drops significantly.
And the kidneys need that flow to filter waste.
Right. For a diabetic patient whose kidneys are likely already under chronic stress from years of fluctuating blood sugar, this sudden drop in blood flow can significantly worsen pre-existing chronic kidney disease. And in severe cases, the dehydration alone can trigger an acute kidney injury, causing the kidneys to rapidly fail.
The iMedix safety advice mentions that while no specific dosage adjustment is officially required for patients with baseline renal impairment, extreme caution is necessary. This seems particularly crucial for elderly patients who might not even feel how dehydrated they are getting.
It is a massive clinical concern for the elderly population. Even without known diagnosed kidney disease, elderly patients naturally have a gradual decline in kidney function simply due to age.
Their reserves are lower.
Exactly. Furthermore, they often have a heightened sensitivity to these gastrointestinal side effects and a diminished thirst response. If an older patient becomes severely dehydrated from a weekend of vomiting due to a dose escalation, the risk of an acute renal crisis is very real and substantial.
So you can't just tough it out.
No, this is why careful, proactive monitoring by a healthcare provider is non-negotiable. You can't just power through it if you can't keep fluids down.
Okay, here's where it gets really interesting, and honestly quite intense from a safety perspective. We've talked about the common GI issues, but the iMedix platform details some severe systemic risks that require an immediate shift in tone. Let's start with the biggest one, the boxed warning.
The black box warning.
Right. For those who don't know, this is the FDA's absolute strongest safety alert. It is literally visually enclosed in a thick black box at the very top of the prescribing information to ensure doctors and patients cannot miss it.
The box warning for Rybelsus, and indeed for the entire GLP-1 receptor agonist class, concerns the potential risk of thyroid C-cell tumors.
Thyroid tumors.
Yes. This warning is based on long-term, high-dose toxicology studies conducted in rodents where semaglutide was definitively shown to cause these specific types of thyroid tumors, including a very aggressive form called medullary thyroid carcinoma.
Now, the iMedix text is careful to note the scientific caveat here. It's currently unknown if this risk translates directly to humans. Rodent biology is not human biology, and their thyroid receptors react differently. But the FDA does not take chances with potential carcinogens.
Exactly. Because of that alarming rodent data, there are absolute black and white contraindications. Rybelsus must never, under any circumstances, be prescribed to patients with a personal or family history of medullary thyroid carcinoma, known as MTC.
MTC.
It is also strictly contraindicated in patients with a rare genetic condition called multiple endocrine neoplasia syndrome type 2, or MN2, which predisposes individuals to these specific endocrine tumors.
So if you have those conditions anywhere in your direct family tree, this entire class of drugs is completely off the table for you.
Completely off the table. It's not a risk worth taking.
That's a very clear line in the sand. But then there's another critical real-world scenario detailed in the iMedix safety concerns that absolutely blew my mind because it's so unexpected: the anesthesia risk.
Yes, this is a huge emerging issue.
This is something that could affect literally anyone on this drug who suddenly needs surgery, whether it's planned or an emergency.
This is a perfect example of how a medication's primary mechanism of action can create totally unexpected, dangerous downstream effects in a completely different medical context.
Let's walk through it.
While we know Rybelsus causes delayed gastric emptying, that's how it helps control blood sugar, the stomach holds on to its contents much, much longer than a normal, unmedicated stomach.
Right, it's the traffic jam effect we discussed.
Now, consider the protocol for what happens during general anesthesia for surgery. When you go under, the body's normal, involuntary protective reflexes, like coughing or your gag reflex, are completely temporarily paralyzed by the anesthetic drugs.
So your airway's unprotected.
Exactly.
Right.
The standard universal protocol before any surgery is to fast, they tell you. No food or water after midnight. The goal is to ensure that your stomach is completely bone-dry empty.
To prevent vomiting while you're asleep.
Basically, yes. This is crucial to prevent any residual stomach contents from passively flowing back up your esophagus and silently slipping into your lungs while you are unconscious and unable to cough it out.
Which is medically called pulmonary aspiration. And from what I understand, it is incredibly dangerous. The acid and food particles essentially destroy the lung tissue.
It can easily be fatal or lead to massive, prolonged intensive care stays. It's an anesthesiologist's worst nightmare.
So where does Rybelsus come into this?
The severe danger with Rybelsus is that even if a patient perfectly follows the standard nothing after midnight fasting rules before surgery, the delayed gastric emptying means those rules are insufficient.
Because the stomach is still full from dinner.
Or even breakfast the day before. There might still be solid food or large volumes of acidic liquid retained in their stomach from a meal they ate 12 or even 24 hours prior. Gastric ultrasounds on patients taking GLP-1s have shown full stomachs days after their last meal.
Oh, wow. So the standard fasting rules just completely fail for someone on this drug. You think you're empty, but you aren't.
They absolutely fail. Taking Rybelsus up to the day before surgery poses a massive hidden risk of retaining stomach contents and suffering pulmonary aspiration the moment they intubate you.
That is terrifying.
The iMedix guide is emphatic about the critical necessity of over-communicating this. You must proactively inform your surgeons and, most importantly, your anesthesiologists that you are on an oral GLP-1.
Don't assume they just know.
Never assume. It typically must be stopped several days, sometimes a week or more, prior to any elective procedure to ensure the stomach has actually physically emptied.
That is vital information for you to know if you or a loved one are ever in that situation. You must disclose it. And the serious warnings in the iMedix data don't stop there. The guide lists a few other severe complications to watch out for. Let's talk about pancreatitis.
Pancreatitis is an acute, incredibly painful inflammation of the pancreas itself. While rare, it's a known risk with GLP-1s.
What does that feel like?
The hallmark symptom patients need to be hyper aware of is persistent, severe stomach pain that is so intense it actually radiates around the sides and into the back. It may or may not be accompanied by persistent vomiting.
And the directive there is incredibly simple and urgent. If you feel that specific radiating pain, you don't wait to see if it gets better. You stop the medication immediately and get to an emergency room to have your pancreatic enzymes checked.
Immediate medical attention.
Another major warning involves hypoglycemia or dangerously low blood sugar. Now, you mentioned earlier that Rybelsus alone has a low risk of this because it's glucose dependent. But what happens when you combine it with older diabetes meds?
The risk spikes dramatically. If Rybelsus is combined with exogenous insulin injections or with a class of drugs called insulin secretagogues like sulfonylureas, a very common one being glyburide, the glucose-lowering effects become aggressively additive.
They stack on top of each other.
They stack. The sulfonylurea is forcing the pancreas to pump out insulin regardless of blood sugar, and the Rybelsus is amplifying the effect. This can drive blood sugar down to dangerous, dizzying, potentially coma-inducing
So
levels.
doctors have to adjust the old meds.
Yes, doctors frequently have to proactively reduce the doses of those older medications when they first initiate Rybelsus.
And finally, there's this incredibly counterintuitive complication regarding eye health, diabetic retinopathy. The iMedix warnings explain this paradox where a rapid improvement in your blood sugar control can actually temporarily worsen existing eye complications.
Yeah.
How does getting healthier hurt your eyes?
It's a known, fascinating phenomenon in endocrinology. When blood sugar has been uncontrolled and running high for a long time, the tiny, fragile blood vessels in the retina become damaged and accustomed to that high glucose, highly osmotic environment.
They get used to the toxic environment.
Precisely. If you introduce a powerful drug like Rybelsus and bring that blood sugar down very rapidly, the sudden osmotic and metabolic shifts essentially pull fluid in and out of the tissues of the eye.
Like a shock to the system.
This rapid shift can cause those fragile, already damaged vessels to leak, or it can worsen pre-existing diabetic retinopathy. It is usually a temporary worsening as the body equilibrates to the new normal, but it requires close, specialized monitoring by an ophthalmologist during the initial phases of treatment.
It's so complex.
Yeah.
Fixing one broken system puts acute stress on another. The body truly is interconnected, which perfectly sets up our next major topic: drug interactions and special populations.
This is where the logistics get really tricky.
Yeah, when I was reviewing the interaction section of the iMedix database, I realized something crucial. Rybelsus doesn't necessarily have chemical conflicts with other drugs. It's not like mixing bleach and ammonia where they react and explode. Instead, it creates purely mechanical timing conflicts.
That is an excellent way to conceptualize it. It is not a direct chemical interaction at the molecular level. It is a pharmacokinetic interaction.
Because of the stomach.
Because of the delayed gastric emptying we keep coming back to, Rybelsus creates a literal physical traffic jam in your digestive tract.
So if you take another pill for a different condition, it just sits there in the stomach acid, stuck in traffic, unable to move past the pyloric sphincter into the small intestines where most drugs are actually absorbed.
Exactly. It significantly delays the absorption rate and alters the peak concentration of almost any other co-administered oral drug. Now, for many routine medications, like a mild painkiller for a headache, a slight delay in absorption doesn't really matter clinically.
It just takes a little longer to kick in.
Right. But for critical narrow therapeutic index medications where the blood levels must be exact, timing is literally everything.
The staggering rules for spacing out pills are intense. According to iMedix, critical daily meds like levothyroxine for thyroid function, certain statins for cholesterol, or specific antibiotics must be taken at a very precise, carefully calculated distance from your Rybelsus dose.
And it's a wide window.
You either have to take them at least 1 hour before you take Rybelsus,
Yeah.
or you have to wait a full 4 hours after taking Rybelsus.
And remember, the unforgiving morning ritual we unpacked earlier. You take Rybelsus absolutely first thing, wait exactly 30 minutes, then you eat. Now add in the fact that you have to wait 4 hours to take your vital thyroid pill.
It's a scheduling nightmare.
It requires a level of daily alarm setting and scheduling that can be extremely burdensome and stressful for patients who are already managing the mental load of multiple chronic conditions.
And if you thought managing a 4-hour window was tough, let's highlight the extreme case of oral contraceptives. The iMedix interaction chart explicitly states that the absorption of birth control pills can be unpredictably reduced by this traffic jam.
With massive consequences.
Exactly. Women must take their oral contraceptive at least 1 hour before Rybelsus, or they have to wait a staggering 11 hours after taking it.
11 hours. Think about that. The 11-hour rule is there to ensure the stomach traffic jam has completely, thoroughly cleared so the hormones in the contraceptive are fully absorbed into the bloodstream.
Because obviously a failure in absorption here leads to unintended pregnancy.
Which is highly problematic given the drug's safety profile during pregnancy, which we'll cover in a moment. Because that 11-hour window is so prone to human error, in many cases, doctors will simply recommend a non-oral backup method.
Like an IUD or a patch.
Right, an IUD, a patch, or an implant to bypass the digestive tract entirely and eliminate the risk of the pill getting stuck in the stomach.
That makes total sense. Why risk it? Another major interaction mentioned is with warfarin, the common blood thinner.
Warfarin dosing is famously delicate and highly individualized. The slightest change in how fast it's absorbed can thin the blood too much, risking severe internal hemorrhage, or thin it too little, risking fatal blood clots or strokes.
So how do they manage that?
Because Rybelsus alters absorption unpredictably, patients on warfarin must have their INR, their international normalized ratio, which is the blood clotting measure monitored much more frequently with blood draws when starting, stopping, or changing their Rybelsus dose.
And speaking of populations requiring special care, the safety advice for pregnancy and breastfeeding is absolute. Rybelsus is categorized as unsafe, period. Animal studies showed significant fetal harm, including structural abnormalities and altered growth.
It is entirely contraindicated.
But what truly blew my mind in the iMedix text was the required washout period. Due to the drug's extremely long half-life, meaning how long the semaglutide physically lingers in your system after you stop taking it, women are strongly advised to stop taking the medication at least 2 full months before a planned pregnancy.
2 full months.
That's a huge window.
A single dose of semaglutide takes about a week to reduce by half in your body, so it takes many weeks for it to fully clear. That 2-month washout highlights just how deeply this medication embeds itself into your metabolic pathways.
And breastfeeding.
Breastfeeding is also strictly not recommended due to the high potential for serious, untested side effects in the developing infant. Furthermore, it is currently categorized as unsafe for children. Safety and effectiveness simply have not been established through clinical trials for anyone under 18 years old.
Okay, what about common lifestyle factors? Alcohol, for instance. People want to know if they can have a glass of wine with dinner.
The iMedix guide advises extreme caution with alcohol, and for several compounding reasons. First, alcohol unpredictably affects blood sugar on its own. It can actually cause delayed hypoglycemia.
So combining it with a blood sugar med is risky.
Exactly. When combined with a GLP-1, it can cause erratic, dangerous drops in glucose. Second, and perhaps more practically for the patient, alcohol is notorious for irritating the gastric lining.
Oh, man.
Right. When you combine that irritation with the delayed gastric emptying and the severe nausea that Rybelsus already causes, it is a recipe for a miserable, agonizing gastrointestinal experience.
Yeah, that sounds like a guaranteed bad night. And as for daily, routine activities like driving to work or operating heavy machinery.
Generally speaking, the semaglutide molecule itself does not directly impair cognitive or motor skills. However, caution is heavily advised because of the secondary effects.
Like what?
Intense dizziness or drowsiness resulting from a sudden drop in blood sugar, especially if combined with other meds or just sheer physical exhaustion and distraction from severe lingering nausea, can absolutely make driving dangerous. You have to know how the drug affects you before you get behind the wheel.
It really touches every single aspect of your daily life. It dictates when you wake up, when you drink water, when you eat, how you handle other meds, and even how you drive.
It's an all-encompassing therapy.
Which brings us to our final area of focus, the real-world application. Let's look at the iMedix community, costs, and the real-world experience. We have to talk about the financial reality because we can't discuss a breakthrough, paradigm-shifting drug without discussing who actually has access to it.
And access is a major issue.
Rybelsus is a branded specialty medication. It is currently under strict patent protection by Novo Nordisk, which means there is absolutely no bioequivalent, cheaper generic available on the market, and there won't be for years.
And that patent protection, combined with the incredibly complex manufacturing process of combining the peptide with the SNAC enhancer, ensures the out-of-pocket cost remains astronomically high.
Which locks a lot of people out.
The iMedix guide directly acknowledges this significant, often insurmountable barrier to entry for many patients.
But they do offer actionable strategies for you to navigate this cost barrier. They suggest aggressively checking with your insurance for prior authorizations, which usually means you have to prove you have formally tried and failed on cheaper, older diabetes drugs, like metformin first.
Step therapy.
Right. They also highly recommend looking directly into the manufacturer's patient assistance programs and savings cards. Novo Nordisk actually has programs that can significantly lower the monthly copay for eligible patients with commercial insurance.
Those can be lifesavers.
And above all, they advocate for having an open, honest discussion with your doctor about affordable alternatives. If the cost of Rybelsus is threatening your financial stability or forcing you to ration doses, which destroys the efficacy anyway.
This is exactly where a platform like iMedix becomes so incredibly valuable beyond just acting as a clinical database. It highlights the real human element of medical treatment. When you step out of the clinical trial data and look at the actual patient discourse on the platform's forums, you see the messy totality of the patient experience.
Yes. The active community on iMedix is fascinating to read through. It's not just clinical questions, it's life questions.
Exactly.
You see user profiles like Just a Guy 35 asking deeply personal questions in the forums about ED issues and how his diabetes meds might be affecting it. Or user Pocase looking for strategies to reduce the intense anxiety she feels naturally without adding another pill to her massive daily regimen.
And Lepexa asking about family nutrition.
Right. Asking how to improve her child's nutrition while she herself is navigating this strict, low-fat, anti-nausea diet. These aren't just isolated data points on a chart. These are real people managing complex, multifaceted lives alongside primary grueling conditions like diabetes.
It perfectly illustrates that a drug like Rybelsus does not exist in a vacuum. The trending tags on the iMedix platform, tags like healthcare costs, alternative therapies, and diabetes management, reinforce that a patient's journey is a highly complex web.
They're balancing so much.
They are balancing the brutal physical side effects of a GLP-1 with their mental health struggles, their family's nutritional needs, and the crushing anxiety of trying to figure out how to pay for it all every single month.
And crucially, in the middle of all that desperation, iMedix acts as a necessary safeguard. I noticed in their medication database section, they explicitly track and flag FDA-approved drugs like Rybelsus, Diflucan, and Amoxil with a very clear, reassuring green checkmark.
Verification is key.
But right below that, they list a whole host of non-FDA-approved, sketchy generics that people search for, things like Comagra or Vitalista, with a glaring red, not approved warning. It shows the vital importance of platforms that actively educate patients, helping them verify safety and steer clear of unregulated, potentially dangerous alternative compounds they might find on gray market internet pharmacies.
Information is a literal form of patient protection. When people are desperate for a GLP-1 and can't afford the brand name, they look for workarounds. Distinguishing between a rigorously tested, FDA-approved peptide delivery system that utilizes a highly specific SNAC buffer and an unregulated, untested internet powder claiming to be a generic is quite literally a matter of life and death. You have no idea what you're actually swallowing without that verification.
Okay, let's synthesize this incredibly deep dive. We have been on quite a complex journey today. We started with the origin story of Rybelsus, recognizing it as a genuine scientific triumph that successfully sneaks a delicate, fragile peptide past the stomach's destructive acidic defenses using a brilliant chemical bodyguard.
A true milestone.
We explored how it offers powerful, glucose-dependent glycemic control and proven life-extending cardiovascular benefits for those with type 2 diabetes. But we also uncovered the incredibly heavy toll it demands. Absolute, unwavering obedience to its 30-minute morning administration rules, and a very high tolerance for its initial, sometimes severe, gastrointestinal side effects.
And we navigated the complex web of pharmacokinetic interactions, the absolute genetic contraindications, and the vital life-saving importance of communicating with your entire healthcare team, especially anesthesiologists, about this medication before any procedure.
So what does this all mean for you? It means that when it comes to cutting edge, revolutionary pharmaceuticals, knowledge, and strict adherence to the behavioral protocol are quite literally just as important as the chemical compound inside the pill itself. A miracle drug only works if you understand exactly how to use it and respect the boundaries it places on your body.
And this is exactly why we rely on comprehensive, transparent resources. It's a final reminder of the profound value of platforms like the iMedix medical content engine. Navigating these complex, modern medical landscapes is not something anyone should attempt to do alone, relying on 60-second social media videos or sensationalized headlines.
Definitely not.
Platforms that provide vetted, rigorous clinical data alongside real empathetic patient community support are essential tools. We encourage you to always consult your qualified healthcare professionals rather than attempting to self-medicate, buy unregulated drugs, or alter your delicate dosing schedule based on internet trends.
Absolutely. Talk to your doctor.
Yeah.
Now, to wrap up, I want to leave you with a final provocative thought to mull over. We spent this entire deep dive discussing the monumental, almost impossible challenge of making a GLP-1 peptide survive the human stomach. The scientists at Novo Nordisk picked a biological lock that was previously thought unpickable.
They really did.
So if this protective oral technology, this SNAC buffer system, exists now, what comes next? We are standing on the precipice of a totally new era in pharmacology. Think about all the other traditionally injected, life-saving biologic therapies out there. Could complex, heavy molecule treatments for rheumatoid arthritis or targeted biologic therapies for rare genetic conditions soon be transformed into a simple daily pill sitting quietly on your nightstand. And if we completely remove the dreaded needle barrier from modern medicine, how will that fundamentally alter human psychology and our collective willingness to proactively manage chronic disease? It's a fascinating future to imagine. Thank you for joining us on this deep dive.